thanks to them. So our main objectives today, what are we going to be talking about is review the anatomy of the sella. So, the pituitary gland is in the sella. So we're going to be reviewing the anatomy of the sella. How does the gland sit there? What are the relationships with different structures and the relationships of other structures with the pituitary gland? We'll review the basics of cellular imaging, what are the different modalities we have, and then develop really an imaging approach to diagnosis of cellular lesions. When we see a cellular lesion, what do we think? If it's a cystic lesion, what do we think of? If it's a solid lesion, what do we think of? If we see calcifications, what do we think of? So we're going to be talking a little bit about all of these things. So as part of imaging, we have two main imaging courses, and one is more heavier than the others. But then the two main workhorses of cellular imaging are the CT and the MR. We can use radiography, and of course, historically, people used to say, the cell is shallow or J-shaped and whatnot. But then that didn't have much of a clinical implication, of course, empty cellular. But then the two main workhorses that we use for cellular imaging are CT and MR. And MR much more than CT because the soft tissue detail, the distinction between the anterior and the posterior pituitary or the pituitary bright spot, so to speak, is much better seen on MR as compared to CT. But on CT, the sella, of course, is this saddle-shaped depression within the sphenoid bone. And anteriorly, we have, certain bony landmarks. So anterior to the sella, we have this bony ridge called the tuberculum sella, which is, again, part of the sphenoid bone. And more anteriorly, we have this bony plate called the planum sphenoidale. Posteriorly, we have, again, part of the sphenoid bone called the dorsum sella. On either sides, we have the anterior clinoid processes. And this is pretty much what we see in terms of the bony landmarks of the sella. Of course, we see much more, many more structures, many more relationships when we look at MR. And as I said, MR is the main imaging workhorse for sella. And when we image the sella, we don't use, of course, we use dynamic imaging, which I'm going to talk about. But most of all, we don't use a lot of fancy imaging. It's just focused images on the sella, and all we need is a pre and post contrast T1 weighted image. So T1 weighted image, which does distinguish between the different parts of the sella, and then we do post contrast imaging. And sella, or the pituitary gland, is unique in the brain in that it is outside of the blood-brain barrier, and therefore the sella actually enhances. And the differential enhancement within the sella is what we use for diagnosing different diseases of the sella. So what we really need is focused sagittal T1 weighted image, a focused coronal T1 weighted image, and then post-contrast sagittal and coronal T1 weighted images of the sella, and that's all we need. And we additionally add a coronal T2 weighted image just to see different tissue characteristics, because there are certain types of tissues that we evaluate, how they behave differently between T1 and T2 weighted images. So we add additionally a coronal T2 weighted image. And here is the cellular anatomy on a pre-contrast T1 weighted image. You can see that there is no enhancement of the nasal mucosa, and this is how we know that this is a pre-contrast T1 weighted image. And on a sagittal pre-contrast T1 weighted image in the sella, anteriorly we see the anterior pituitary or the adenohypophysis, and posteriorly we see this posterior sella bright spot. Now, there is, of course, still a lot of controversy whether this posterior sella bright spot is actually the neurohypophysis, because a lot of people say that, it is not the neurohypophysis. There are, different kind of cells in the posterior pituitary bright spot that give it that particular shape. But then, for all practical purposes, we see an anterior portion of the pituitary gland, which is the adenohypophysis, and a posterior sella bright spot, which does show, different displacement when we talk about, things like diabetes insipidus, which does affect the posterior pituitary, and in that case, it becomes ectopic and seen at different locations. And in other diseases which cause diabetes insipidus, we do see absence of the posterior pituitary bright spot, which does sort of tell us something about the relationship between the neurohypophysis and the posterior pituitary bright spot. So this is a pre-contrast T1 weighted image where we see the adenohypophysis, we see the posterior sella bright spot, we see the infundibulum that is extending from the hypothalamus to the pituitary gland itself, and then more anterior to the pituitary, the stalk or the infundibulum is the optic chiasm that we see on a pre-contrast T1 weighted image. And as I said before, on a post-contrast T1 weighted image, the sella or the pituitary gland actually enhances because it is outside of the blood-brain barrier. Normal brain structures do not enhance because there is a blood-brain barrier which stops the entry of contrast in the brain tissue unless there is a disease. Of course, if there are tumors, if there is an infarct or other diseases, that blood-brain barrier is disrupted and those things enhance. But pituitary gland, because it's outside, and the pituitary stalk, because they're outside of the blood-brain barrier, they normally enhance. And this is what we see. This is an enhancing pituitary stalk. This is an enhancing pituitary gland, which on post-contrast images actually enhances homogeneously. There is no distinction between the posterior sellar bright spot and the adenohypophysis on a post-contrast T1 weighted image. And again, in this, we can see that it extends from the hypothalamus to the pituitary gland. More anterior is the optic chiasm. And then posteriorly, we see this another bump, which is the mammillary body. And the portion of the hypothalamus from which this pituitary stalk extends is the tuber cinereum. So a gentle sort of bump on the hypothalamus from where the pituitary stalk extends is the tuber cinereum. And tuber cinereum is also important because one of our lesions actually are centered in the location of the tuber cinereum, the tuber cinereum hematoma. And again, a good way to identify whether or not we are dealing with a post-contrast T1 weighted image is again to look at the nasal or the adenoid mucosa. We can see that the nasal mucosa is enhancing, and that's how we can deduce that this is a post-contrast T1 weighted image. Then, since we are talking about normal pituitary, it's important to know the size of the pituitary gland. So these are the different ranges of the size of the pituitary gland, and it is most prominent or most bulky in prepubertal children in third trimester pregnancy and first week postpartum when the hormones are sort of flowing from the pituitary gland. And this is sort of a good a way to know whether or not we are dealing with something like pituitary hyperplasia, which can occur in postpartum patients, can occur in patients who have primary hypothyroidism because of increased secretion of glands from the hypothalamus, which are stimulating the pituitary gland. And this is probably a good point where we show what pituitary hyperplasia looks like. So this is a homogeneously enhancing gland, and you can see how this looks different from that normal pituitary that we showed that have almost a concave superior margin. But when we see this convexity on the superior margin of the pituitary gland, which is diffusely enlarged and is more than the normal range of size, and it is without deviation of the pituitary stalk because the gland as a whole is enlarged and enhancing. If we see a gland that has a convex superior margin is increased in height from the normal measurements and has a midline pituitary stalk that is undeviated, in the correct clinical setting of a postpartum female or in hypothyroidism, we should think of pituitary hyperplasia, which is what this is. And this is how we sort of can differentiate a pituitary hyperplasia from pituitary adenoma or a microadenoma, macroadenoma, because those are usually sort of on one side and are associated with deviation of the pituitary stalk. So if you see an enlarged gland that has no deviation of the pituitary stalk in the correct clinical setting, we should think about pituitary hyperplasia. Then this is also probably a good time to talk about empty sella. Empty sella can be a normal variant, and it is hardly ever completely empty because there is always some pituitary tissue at the base of the sella. It can be normal variant in in old people when there is sort of decreased pituitary tissue. And empty sella is also associated with pseudotumor cerebri. So if we see it in young patients who have dilatation of the optic nerve sheaths, if they have proper clinical setting, if they have stenosis of the transverse venous sinuses, then empty sella in that case can also be associated with pseudotumor cerebri. Then, this is also probably, we already talked about that. We talked about the controversy of whether or not neurohypophysis is really the posterior cellular bright spot. But, in children who have diabetes insipidus, the ectopic pituitary tissue is usually seen at the at the base of the hypothalamus. And if we see absence of posterior cellular bright spot, and there is sort of abnormal location of the ectopic posterior pituitary, this is something that is associated with diabetes insipidus syndrome. And this is a very characteristic finding of ectopic location of the posterior pituitary gland. Any questions so far? All right, so we talked about the anatomy of the sella, what this the gland looks like normally, on normal T1 and post-contrast T1 weighted images. What is the normal size of the pituitary? When do we say it is pituitary hyperplasia? When it's increased in size, diffusely enlarged with midline stalk. We talked about what an empty cella looks like. These are on sort of normal variants. And then we talked about the ectopic position of the posterior pituitary gland in cases of kids who have diabetes insipidus. Now let's talk about paracellular anatomy, because that is also very important, because paracellular structures can also have pathology and can extend into the cella and can be confused with cellar lesions. So this is a sort of a cartoon diagram of coronal images through the cella. And of course, this is the cella, this is the pituitary gland itself with pituitary stalk. And on either sides of the cella, as we know, are the cavernous sinuses, which are these venous sinuses, which are valveless. And the lateral wall of the cavernous sinus itself is very important, because several nerves actually traverse through the lateral wall of the cavernous sinus, top to bottom. And from top to bottom, these are the oculomotor nerve, that is the cranial nerve 3. Then we have the trochlear nerve just inferior to the cranial nerve 3. Then more inferiorly, we have the V1 and the V2 nerves, which are branches of the trigeminal nerve. We don't have the V3 nerve here because that has already exited the skull base from the foramen valley. So we don't see V3 in the lateral wall of the cavernous sinus because that has already exited, but because V1 and V2, because they're going towards the orbit and towards the infratemporal fossa, we do see them on the lateral wall of the cavernous sinus. We do see another nerve here within the substance of the cavernous sinus, which is the abducens nerve or the cranial nerve 6. Again, this is going towards the orbit to supply the extraocular muscles. And then within the substance of the cavernous sinus, we do also see the internal carotid arteries. And this is what it looks like on imaging. So this is a coronal image through the cella. Again, as I said, all we need for cella imaging are pre and post contrast T1 weighted images. This is a post contrast coronal T1 weighted image that shows that anatomy. So, this is up top, we have the optic chiasm. Here we have part of the pituitary tissue. And on either sides, we have these intensely enhancing structures. They are the cavernous sinuses. Of course, they have blood, they enhance intensely, and these are the cavernous sinuses. And these flow voids, the black structures, because they contain, fast-flowing blood, they cannot be magnetized and usually produce a flow void. We see these ICA flow voids within the substance of the cavernous sinuses on each sides. And on the lateral wall of these cavernous sinuses, you can see all those neural structures that we just talked about, top to bottom. At the top, we have the cranial nerve 3, which is this one. Just below that, this little sort of filling defect in the lateral wall of the cavernous sinus is the trochlear nerve. Just inferolateral to the internal carotid artery, we have the abducens nerve here. And then more lower down, we have the V2. And here, more superiorly, we have the V1. Of course, we can't see the V1 here that well, but on the other side, you can see that the V1 is here and the V2 is here. So cranial nerve 3, 4, V1, V2, and then cranial nerve 6 that goes within the substance of the cavernous sinus, inferolateral to the flow void of the internal carotid artery. And this is how these lesions, these structures can have lesions that can sort of extend into the cella. So here is an aneurysm of the internal carotid artery that is in the paracellular region. It can, of course, sometimes extend into the cella. There can be a bony remodeling of the lateral wall of the cella, and sometimes these can mimic cellar lesions. Here is a schwannoma of the fifth cranial nerve, and again, these schwannomas are usually in the lateral wall of the cavernous sinus, but they can get big and they can sort of extend into the sellar region. Then, any questions so far? All right. So the most common lesion that we encounter when we are talking about sellar lesions is going to be a pituitary adenoma. And pituitary adenomas usually come sort of in two flavors. Or maybe, it's just a distinction of size. So they can be pituitary microadenomas that are less than 10 millimeter or 1 centimeter, and pituitary macroadenomas, which are more than 10 millimeter or more than 1 centimeter. And as I said, because these adenomas have a tendency. So going back, as I said, pituitary tissue itself enhances avidly. It is something that is outside the blood-brain barrier, enhances avidly. But microadenoma or adenomas, microadenoma or macroadenoma, are lesions that enhance less intensely compared to the pituitary tissue, and that's why when we see a structure that is enhancing less intensely than the pituitary tissue itself, we think of a pituitary adenoma. And this is what it looks like. You can see that there is a hypoenhancing, and that's why they're described as hypoenhancing lesions. So hypoenhancing lesion on the right aspect of the sella, we see it here against the intensely enhancing pituitary tissue. And this is another pituitary microadenoma that is hypoenhancing and is within the substance of the pituitary gland. So these microadenomas can be commonly seen in patients who are presenting with endocrine abnormalities, most prolactin or prolactin abnormalities, with other Cushing's disease or thyroid abnormalities as well. And most of these can be seen with just the imaging that I described, T1 and T2 weighted imaging. But there is another technique that is commonly described with detection of these microadenomas, and that is a dynamic contrast enhanced MRI of the sella. And in this, what is done is that serial images are obtained through the sella as the contrast is being injected, and the logic or the rationale behind obtaining the dynamic contrast sequences is again the same, that the enhancement of the adenoma is less than the enhancement of the pituitary gland itself. And as you can see on these ciliary images, the enhancement of the pituitary tissue itself starts very quickly. You can see that all these images, there is already enhancement of the pituitary gland. And this lesion that is enhancing less than the pituitary tissue itself is sort of, it jumps out as contrast to this intensely enhancing pituitary tissue. Over time, some of these lesions may enhance as much as the pituitary gland, and that's why we do this dynamic contrast enhanced sequence. But then it is this hypoenhancing structure that we have to localize and visualize against the enhancing tissue, enhancing pituitary tissue, which helps us identify smaller adenomas. Now, these days, people are also talking about nuclear medicine techniques, and dose-to-date imaging has come in handy, or some people are doing research on that and saying that dose-to-date can actually detect more adenomas than even MRI. And again, the rationale is that dose-to-date is actually, because it is a somatostatin analog, it binds to the pituitary tissue, and the pituitary enhances with dose-to-date administration. And if there is a microadenoma, again, it will appear as a filling defect against that, avidly enhancing, so to speak, pituitary gland, because that all the tracer will be taken by the gland itself, and the adenoma is not going to take up that tracer. So, I mean, we are not doing it here right now, but the literature, people are doing research on this, and there is literature out there that says that dose-to-date technique can be more sensitive than even MRI for detection of smaller microadenomas. Then, yeah.
Hi. So the dose-to-date with small lesions is not that good, at least not when we're looking for neuroendocrine tumors that make ACTH elsewhere in the body. And think that's probably the case in the pituitary as well. At Cambridge in the United Kingdom, they do have C-methionine, and that's really sounds like a promising nuclear medicine test for those invisible HTH secreting adenomas in the pituitary, which are 20% of the tumors that secrete HTH, but we don't have it in the US. So my question has to do with other MRI protocols that may put, help us. We only need to know about small tumors when they secrete HTH and cause Cushing's disease. For the remainders, we don't really, we're not that concerned because these are benign tumors with very slow growth. But for Cushing's disease, it's different. So I came from Emory University last year, and there are other studies in the country, and we've even published our literature there with regards to other MRIs parts that are not done elsewhere. So, for example, the VIBE technique. And also, I think it's important how thin the section is for the pituitary. So not all MRI scans are created the same. It depends how many Teslas, it depends how thin. So what would be your recommendation for the tumor that is not found on the regular MRI, even on the dynamic Sellar?
Yeah, I think there is an argument for moving even away from dynamic imaging because a lot of people say that dynamic imaging is not that useful with the use of thin slice imaging, for example, VIBE or other 3D SVGR sequences that are really, T1-weighted sequences that are sort of designed to obtain very thin slices. So, even in the literature, people say that there is probably not a big use of doing dynamic contrast sequences because if you use other kind of sequences like 3D SPGR or VIBE, they are much more sensitive at detecting smaller adenomas compared to the normal sequences. You brought up the other tracer, methionine, that is useful. The other PET MRI technique that some people talk about is a combination of FDG with dotatate because they have different sort of uptake. So FDG is usually taken up by adenomas, whereas the dotatate is taken up by the normal pituitary tissue. And that differential tracer uptake by adenoma and the gland itself, again, has higher sensitivity than thin slice MRI or using dotatate alone. So there is research going on differential enhancement or use of two tracers instead of one to localize smaller adenomas.
Yeah. Can we get VIBE here?
So we have 3D SPGR, which is like a VIBE. Don't routinely use it, but yeah, if this is something you would want to use, I think this would be more like a conversation with people who design protocols and see if we can do thin slice imaging instead of the normal. I think we do use 2 mm sections. So yeah, it's definitely doable.
Maybe we can do it like with a research protocol, for example. We see all these patients with Cushing's disease, and we can put them through the two different ways of imaging them.
Sure. Yeah. I mean, if there is a
it would be cool. Right?
Sure. Yeah. If there is a cohort of patients where you think normal imaging is not going to be useful, and you have 3 or 5 of such patients, and you want to use that particular protocol, for sure, we can sit down and chat and involve the people who design protocols and come up with something. Yeah, absolutely. So, again, continuing our talk on adenomas. So we talked about microadenomas and how what are the different ways in which we can localize smaller tumors. When we go beyond the smaller tumors, when you talk about macroadenomas, then of course at that point, localizing the lesions is not that important because we know we are dealing with a big tumor. But then in that case, what becomes important is the extension of the tumor. So when we look at macroadenomas, we want to know whether or not they are involving other structures. So the three sort of directions where these macroadenomas can go, they can go up, and superior to the sella is the optic chiasm. So when we have tumors that extend to the suprasellar region, we have to identify and make sure that it's not involving the optic chiasm. And here we have a macroadenoma. You can see that the optic chiasm is sort of stretched out and is compressed. So these patients are going to present with the typical visual symptoms that are common with the pituitary macroadenoma. So again, this is another case in which we can see that the optic chiasm is displaced and stretched. Then they can go sideways. They can have parasellar extension, and here we have two different macroadenomas that have a parasellar extension. So this one is extending into the left cavernous sinus. It is encasing the left internal carotid artery, and here is where this sort of classification system becomes important, the NOSP grading, which tells us whether or not there is invasion of the cavernous sinus. What we do in NOSP grading is we have three tangents that go along the medial aspect of the internal carotid artery, along the lateral aspect of the internal carotid artery, and then one that goes through the middle of the internal carotid artery. And serial extension of tumor beyond these lines decides what grade the tumor is on the NOSP grading. And the greater the extent of parasellar extension, the greater is the likelihood that we have a subtotal resection, because if there is a gross extension into the cavernous sinus, those tumors will not be entirely resected. So this is what we generally use when we are talking about parasellar extension. We say whether or not it is. And sometimes you won't see people actually grading it according to the NOSP grade, not saying that it's, NOSP, 2A or 2B, but then most people do describe whether or not it is, beyond the level of the internal carotid artery, or is medial to the level of the internal carotid artery. So the description would imply which NOSP grading it is, but then it's those three tangential lines that we like to look at when we are deciding whether or not there is cavernous sinus extension, or whether or not that particular tumor is going to be completely resected or not. Then the other direction it can go inferiorly, and when it does go inferiorly, it erodes the skull base. There can be extension into the sphenoid sinuses, which this one is going. So there's a large tumor here that has extended into the sphenoid sinus. This is the same tumor, and this is a CT image in which we can see that there is extension into the skull base with erosion of the base of the skull. Then pituitary adenomas can undergo hemorrhage. So we talk about pituitary apoplexy or pituitary hemorrhage, which is most common in patients who already have a pre-existing adenoma. Of course, these patients present acutely with headaches, with visual symptoms, with endocrine abnormalities. And on imaging, what we see is blood products within the sella. On CT, those blood products are going to appear hyperdense. As we see here, hyperdensity means that there is hemorrhage into the adenoma. And on T1 weighted images, the blood appears hyperintense on T1 weighted images again. So usually subacute blood appears as hyperintense on T1 weighted images. If you see fluid levels, that is another indication that there is hemorrhage into the lesion itself. Sometimes proteinaceous or mucoid contents can also appear hyperintense on T1, and there might be a confusion whether or not this is mucoid Rathke's cleft cyst, or there is hemorrhage into a macroadenoma itself. Usually, if there is a mucoid Rathke's cleft cyst, it is very well defined. It is usually homogeneous, and the patient, of course, is not going to present acutely with headache and other symptoms. But if there is hemorrhage into an adenoma, it is usually, even though it is T1 hyperintense, it's going to be heterogeneous. If there is pre-existing imaging available, we can see that there is enlargement in the side of the adenoma itself. And on CT, whereas a cyst is hypointense, that is dark on CT, hemorrhage is usually going to be hyperintense, because that is what blood products look like on CT. Any questions on that? All right. And this is what I was talking about, Rathke's cleft cysts. Usually they are cystic, they are hypodense on CT, as we can see here. They are homogeneous. They usually do not enhance, and you can see stretched pituitary gland around the Rathke's cleft cyst. But sometimes they can appear hyperintense on T1 weighted images, and that is because of their high protein or mucoid content. But usually they are homogeneous. They don't have that heterogeneous appearance that is usually common with hemorrhagic macroadenomas or apoplexy. Then hypophysitis is another thing that we can see with pituitary adenomas. They can be, again, they can, in adults, they can be symptoms of diabetes insipidus. And again, when we have inflammation of the pituitary gland, whether it's autoimmune, whether it's related to neurosarcoid, whether it's related to some kind of drug intake, in these cases, again, there would be loss of the posterior sellar bright spot. So loss of the posterior sellar bright spot associated with enlargement of the gland itself, thickening of the pituitary stalk, and enhancement is usually what we see in pituitary hypophysitis or inflammation of the pituitary gland, whether related to autoimmune diseases or related to any kind of granulomatous disease. Then there can be other lesions, around the sella that can look like sellar lesions. Here we have an example of a meningioma, which is actually a dural based, is on the anterior wall of the sella itself, and you can see that this is homogeneously enhancing, but the pituitary gland itself is separate from it. So, if we have an intensely enhancing lesion that is not in the sella, but is in the parasellar location, then we think about other lesions that can extend into the sella itself. Then this is the other thing that I was talking about. So if we see a non-enhancing lesion in a child with relevant history with gelastic seizures, which is in the region of the tuberosinium, we think about a tuberosinium hamartoma, which is what this is. Again, this is a nodular structure in the region of the tuberosinium without enhancement. These can get really big too, but then again, there would be no associated enhancement. And when we see a non-enhancing lesion with relevant history in that location, we think about a tuberosinium hamartoma. Then craniopharyngiomas are another suprasellar lesion that are commonly confused with sellar pathology or with sellar lesions. They have bimodal distribution. They can be in kids or in older population. And typically what we see is sellar and suprasellar mixed solid cystic lesions. Craniopharyngiomas commonly calcify, which is another thing that is unusual with the sellar lesions because most adenomas or macroadenomas do not calcify. So if we see a calcific lesion in the sellar or suprasellar location which has cystic change, especially in kids, we think about craniopharyngiomas. Then germinomas are other tumors that are common in kids, again associated with diabetes insipidus commonly. Again, whenever we have that kind of history, we know that we'll be seeing absence of the posterior sellar bright spot, which is what we see on pre-contrast T1 weighted images here. There is no posterior sellar bright spot. There is a mass in the sellar suprasellar region, which shows intense enhancement. Again, if we see this kind of picture in a kid, we think about a germinoma. Now, this kind of picture can also, so if you remember the images of hypophysitis, where there is diffuse enlargement of the gland itself with thickening of the pituitary stalk, that kind of appearance can be seen with Langerhans cell histiocytosis in kids. And since germinomas are also common in kids, there can be a confusion whether we are dealing with a germinoma or a Langerhans cell LCH case. But usually in LCH, you will see other abnormalities because LCH has, all those little bone lesions. There would be, spinal lesions as well. So if you see this kind of picture with bone lesions elsewhere and with other spine abnormalities, you think about LCH. But when you have absence of the posterior sellar bright spot and you have this kind of lesion in a kid with diabetes insipidus, then you think about germinomas. And I have a few slides later where I deal with this kind of differential diagnosis. Then optic chiasm hypothalamic astrocytomas are again tumors that you see in the suprasellar region in kids. These are centered at the optic chiasm and hypothalamic region, again heterogeneous, mostly solidly enhancing. But in kids, these lesions are of the pilocytic variety, which usually have a cyst with mural nodule kind of appearance. So if here on this image, you can see that this intensely enhancing mass also has cystic components. So if you see a cyst with mural nodule or a mixed solid cystic lesion in the optic chiasm region in a kid, especially in a younger kid, then we think about optic chiasm astrocytoma. Usually, optic pathway gliomas are common with neurofibromatosis. So other NF lesions will also be associated with this lesion in the suprasellar region. And this is sort of a differential. So, what do I think about? So when we see a sellar lesion, what do we think? Uh, the first thing that I look at when I look at a sellar lesion, how old is the patient? That's number one. Is this a kid I'm talking about? Is this an adult? What is the nature of the lesion that I'm looking at? Is it cystic? Is it solid? Is it intensely enhancing? Is it not enhancing? Does it have calcification or not? So here is sort of a differential of a sellar or suprasellar lesion in a child. So this is a kid, and if we see a non-enhancing cyst, a cystic lesion in the sellar that absolutely does not enhance, I think of a Rathke's cleft cyst. If there is a mixed solid cystic lesion that shows enhancement but is heterogeneous, mixed solid cystic, and it does not show any calcification, I think of an astrocytoma because craniopharyngiomas, the vast majority of them are usually associated with calcification. So if I don't see calcification, it's a younger kid, and maybe I see lesions of neurofibromatosis, then I think about a optic chiasm astrocytoma. And if I see calcifications, then I think of a craniopharyngioma because other lesions usually do not calcify. So if I see a suprasellar mass which shows heterogeneous enhancement and has calcification, then I think of a craniopharyngioma. If I see a lesion that enhances solidly, there is solid enhancement, there may be some cystic change, but most of the lesion just enhances solidly, intensely, then I think of a germinoma. Again, we are talking about kids here, so I think about a germinoma. Then if I see something that enhances, there is enlargement of the pituitary gland, there is enhancement of the pituitary stalk, but this is associated with other lytic lesions in the bone and the spine, then I think about LCH or Langerhans cell histiocytosis. And then if I see a solid lesion that does not enhance at all and is associated with gelastic seizures, then I think of a tubercinarium hamartoma. So this is sort of a broad differential of sellar or suprasellar lesions in the pediatric age group. Now, if this is an adult, then the differential is slightly different. If it's a non-enhancing cyst, it's probably, again, a Rathke's cleft cyst because they are vastly more common than other kind of lesions. If I see a hypoenhancing lesion, which is less than 1 centimeter, it is hypoenhancing against the enhancing pituitary tissue, then I think of a microadenoma. Then other larger lesion that has suprasellar, parasellar extension, I think of a macroadenoma. If I see a suprasellar mass with cystic change and calcification, again, craniopharyngiomas can be there in adult population, especially with the bimodal distribution. Again, I think of a craniopharyngioma. And then if I see an adult person with diabetes insipidus, they have a thickened pituitary stalk and the gland, then because this is not a kid, I don't think of germinomas, but I do think of lymphocytic hypophysitis. Lymphocytic hypophysitis can be in the setting of autoimmune lymphocytic hypophysitis. It could be drug-induced. It could be related to neurosarcoid or other kind of granulomatous disease. So this is sort of my broad differential when I look at different sellar lesions in the adult population. Now, a word about post-op sellar, because commonly we have these macroadenomas that are surgerized, and we look at post-operative imaging of the sellar and want to know whether or not there is recurrence. And when I look at post-op sellar, this is what I'm reminded of. It's like it's kind of comparing the post-op image with the current image. So the immediate post-op image is our guide, and that is what we use as a baseline to look at all the other images that come after that, because we really want to compare that post-op appearance with the follow-up image. And this is what we do. This is a post-op sellar which shows this kind of a resection cavity. There is some enhancement of the flap itself, and this is a follow-up image where we wanted to see whether or not there is recurrence. And it's just a matter of comparing the two images. Right here, I'm not seeing any kind of nodular enhancement, whereas on the follow-up imaging, I'm seeing that there is a lot of nodular enhancement in the paracellar region. Even here, this was just a linear enhancement of the flap itself, but on this image, I'm seeing a lot of nodular enhancement on the follow-up images. So when I see a difference of the follow-up image from the post-op image, and if I see any kind of nodularity that is enhancing, that is when I'm concerned about tumor recurrence in post-op imaging. Post-op Sellar really becomes distorted because of all the post-op changes, of course, but then that kind of comparison of the immediate post-op appearance with the follow-up imaging is really useful for detection of recurrent disease. Then we already talked about PET MRI in Sellar a little bit. This combines the MRI advantages of greater soft tissue detail with the tumor localizing properties of FDG. It may be useful in identifying tumor recurrence because FDG is taken up by the tumor. And then we talked about dotatate, which has been found to have greater sensitivity for detection of microadenomas. So take-home points. Anatomic localization, so whether the lesion is in the sellar or the paracellar region or the suprasellar region, really tells us what disease pathology we are dealing with. And then the next is age. So we try to see whether it's the sellar that's abnormal, or the pituitary tissue that's abnormal, or it's the extra pituitary tissue that's abnormal, or if the lesion is in the paracellar region. Then we talk about age, and then presence of cystic change, calcification enhancement is useful in deriving a conclusion. I hope this was worth your time. Thank you very much. And if you have any questions, I'm open to them.
Great. So I'll also open it up to anybody online. If you want to unmute or put in the chat box, feel free to throw out any questions. I'll ask the audience or start myself. So you just talked about post-op imaging, and I think that's one of the most challenging things for us, because though we look at some post-op images, we don't always see them. And I think in the cella is maybe not as difficult when we get into the cavernous sinus. I mean, are there any tips or suggestions you have for us, about comparing post-operative, especially paracellar areas?
Yeah, so one thing that has always helped me is to look at the first tumor image, because tumor recurrence, the intensity of the primary tumor, how it enhances and what it looks like resembles very much the recurrence itself. So because it's the same tumor that got left behind and is growing now. So looking at the very first image, unoperated, untreated, really gives me a sense of what that tumor looked like and how the recurrence looked like. So in terms of comparing the tissue, I think that is very useful. But beyond that, I think what I said is what we use is to really compare, image by image, which lesion, which part of the image looks different. What I do is I link the two images and I just go, one by one, and see what anatomy looks different from the index comparison. And that is what usually helps me in identifying whether or not there is any recurrence in the sellar or outside the sellar.
Thanks.
Is that?
Yeah, absolutely. Okay. Other questions? I guess I'll throw another question out there. So more what you see kind of down the line, you talked about functional with FDG and dotatate. Any other imaging modalities or sequences that you think might be helpful in the coming years for cellular imaging?
Not that I have encountered. I think PET MRI is something that's coming up big time in tumor imaging, and I think PET MRI as more and more techniques develop and more tracers develop, I think that is something that would become useful in the future. But in terms of, I mean, there are other imaging modalities that are routinely used, besides the two that I talked about. So, for example, not these tumors, but some people use diffusion-weighted imaging, for example, for tumor recurrence too, but also to look for lymphomas. Diffusion-weighted imaging lymphomas really restrict diffusion. So if that is something that we are thinking about, then we use diffusion-weighted imaging. diffusion weighted imaging is also useful in tumor recurrence, like you were talking about, because what diffusion is a sequence that really measures the diffusivity of water molecules in a tissue. And wherever there is tumor, because tumor cells have a high neutron to cytoplasmic ratio, there is very less water in that tissue. So the diffusivity of water is restricted in tumor tissue. And so, and of course, a lot of research has been done on this. And people say that the area that has the tumor shows reduced diffusivity compared to tumor, compared to regions where there is no tumor or if it's just post-op change. So diffusion rate imaging is definitely useful, or is one technique that is not routinely used that can come in handy if there is question about tumor recurrence.
Great, thank you.
Yeah.
Any questions from our virtual audience? If not, I'll say thank you. Thanks for the introduction.
Thank you very much.
Later today or
On until
tomorrow?
5:45.